Hello, I'm Jean-Jacques Kiladjian, hematologist in Saint-Louis Hospital in Paris, France, and would like to discuss today with you the unmet need of anemia in patients with myelofibrosis. Indeed, anemia is a real complicated issue for patients with myelofibrosis because it's frequent, present in almost 40% of patients at diagnosis, this proportion going up to 60% after 1 year after the diagnosis. Second, it has a big impact on the prognosis of these patients. And maybe you remember the first prognostic score in myelofibrosis developed many years ago. That was the Lille score. At that time, only two parameters were interesting for defining the prognosis of the patient, and one of them was the hemoglobin level. And this hemoglobin level, and with a threshold of 10 grams per deciliter, remained a very potent risk factor still present in all the prognostic scores that have been developed since then. Third, we know that anemia is difficult to address because it's multifactorial in these patients. Obviously, there's a part of ineffective erythropoiesis due to the fibrosis that develops in the bone marrow. But there's also a part of sequestration in the big spleen that patients will develop with time and with progression of the disease. And sequestration and hemodilution also plays a role in anemia. There's also a role that was more recently recognized of the inflammatory context that is around patients with myelofibrosis that impairs also the proper production of red cells and playing also with the hepcidin levels and the iron metabolism, which is perturbed in these patients. And finally, on top of that, you also have the role of the drugs, and in particular, JAK inhibitors. Obviously, the first one that was available many years ago now, ruxolitinib, completely changed the life of our patients, improving largely their symptom burden, their splenomegaly. But on the other hand, JAK2 inhibition per se induces anemia because JAK2, as you know, is a key factor for producing red cells on the hematopoietic stem cell level. So inhibiting JAK2 has an on-target adverse effect, which is development of anemia. Indeed, that's what is observed mostly with ruxolitinib. As you know, at the beginning of the treatment, you often see a decrease in the hemoglobin level that sometimes comes back to the baseline level after a few months of utilization, but also requires sometimes dose adaptation and dose de-escalation, and then loss of efficacy of ruxolitinib. So we have now 4 JAK inhibitors. 3 of them are approved in the European Union, ruxolitinib, fedratinib, and momelotinib. And the fourth one, pacritinib, is currently only approved in the US and still an investigational drug in Europe. However, what is the difference between these 4 JAK inhibitors in terms of anemia? Well, indeed, 2 of them, momelotinib and pacritinib, also have as a target of inhibition ACVR1, which is a receptor which is not on hematopoietic stem cells but on hepatocytes, and that regulates hepcidin production. And by inhibiting this receptor, ACVR1, you will make the iron again available through the hepcidin for the erythropoiesis and then see an increase in hemoglobin level. And this was shown in the clinical trials. So if we discuss of the momelotinib, for example, which is approved in the European Union, we have seen an improvement in the hemoglobin level compared to ruxolitinib in the first-line study, for example, that was performed comparing head-to-head momelotinib to ruxolitinib, but also in the most recent Momentum phase 3 study that compared momelotinib, to best available therapy in patients already exposed to a JAK inhibitor and who had an anemia, showing an increase in the hemoglobin level, a decrease in the rate of patients requiring transfusion with momelotinib compared to the danazol arm, which was the comparator in that study. So this improvement of hemoglobin level induces probably better symptom control of the patients, and in particular fatigue, but also some post-hoc analyses have shown that restoring an hemoglobin above 10 grams may be associated with better overall survival on the long term. So altogether, anemia is complex, frequent, but also has a huge impact on patients' prognosis and quality of life, and is not answered fully today with JAK inhibitors. Maybe two of them, momelotinib and pacritinib, may have a better impact on anemia, but we also look forward for combinations therapy with drugs that may improve the anemia in patients already on JAK inhibition. And for example, we have the results now of the MANIFEST-2 study that tested the combination of ruxolitinib plus pelabresib in patients as first-line therapy, JAK inhibitor naive, and that showed that the addition of pelabresib to ruxolitinib resulted in better control of the hemoglobin level and less anemia in these patients, and could offer another option to address the splenomegaly, the symptoms, but also anemia in patients with myelofibrosis. Thank you for your attention.